Hello students, this is the first podcast for the child with conditions that may alter fluid and electrolyte balance. After that, we will be talking about children with altered gastrointestinal alterations. The concepts that we will be discussing today, you can read there. First, we're going to do a little bit of review here. Fluid balance in children is different than adults. All right, children have a greater need for water. They have a increased extracellular fluid need. They have a increased body surface area, and what that means is their body and their heads proportionally are much larger than their arms. So we're not saying that they have more body surface than an adult, but what we're saying is per their size, they actually have more body surface area. They have an increase in basal metabolic rate as well, and that the basal metabolic rate, is the rate of how many calories they burn every 24 hours while resting, okay? So they have less backup, really, all right? Kidney function is still immature, which we discussed when we were talking about absorption of medications. So as far as fluid requirements, infants ingest and excrete greater amounts of fluid per kilogram than older children even. It is very important for them to maintain fluid requirements, and that depends on their hydration status, their size, the environment, in any type of underlying disease, okay? That formula at the bottom, you see there 100 milligrams per kilogram for the first 10 kilograms, and 50 milliliters per kilogram for the second 10 kilograms, and then 20 for the remaining kilograms per weight. That is our calculation requirement for fluid replacements for children, okay? There is a worksheet in your packet that we are going to do in class. But just understand that the intake for children, infants, children, should exceed their output, all right? I will tell you that vomiting, diarrhea, and no feeding, missing 2 feedings could become a medical emergency, all right? So if those 3 things occur, that child needs to be seen immediately. They cannot go a full day with vomiting, diarrhea, and not eating, all right? Especially infants. So understand that that kind of fluid status that we're talking about can be a medical emergency. The younger they are, the less backup they're going to have, okay? To kind of give you a further review, there are 3 main types of dehydration. Isotonic, which is the primary form of dehydration in children, and this is a condition where the deficits in electrolytes and water are equal, so there's equal deficits here. Hypotonic dehydration is when the electrolyte deficit exceeds the water deficit. Specific signs and symptoms for hypotonic dehydration, you're really going to see restlessness, weakness, and nausea, okay? Hypertonic dehydration is the most dangerous type. This is when our water loss exceeds electrolyte loss. The child will most likely have a headache, have thirst, extreme thirst, have weight loss, and have fatigue. The extent of the dehydration must be evaluated. So we're going to look at the weight loss in the infant or child, the pulse, the blood pressure, behaviors, thirst, their mucous membranes, their fontanelles, their skin turgor, their urine specific gravity is going to be increased if they're dehydrated, remember. They won't have any tears when crying. The picture that you see there, you can see that tongue is dry, 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 and so is, this is representing dry mucous membranes. The eyes of this infant are severely sunken, and this is what's called modeling in an infant. All right, and this is a form, this can be indication, excuse me, of dehydration. I also want you to know it could be indicative of the infant being cold. So you're going to have to do more than just assess that and jump to a conclusion from that assessment, okay? As far as the clinical manifestations of dehydration, so the signs and symptoms, we're talking about weight loss. This is for all the types of dehydration. Weight loss, decreased urine output, tachycardia, dry skin, mucous membranes, dry, no tears, sunken fontanelles. So you're going to see, you possibly may see a sunken fontanelle in an infant. And this is a good way to evaluate their hydration status, because as they become more hydrated, their fontanelle will slowly fill back up. All right, so that's one way you can evaluate if their hydration status is getting better. Delayed skin turgor, lethargy, irritability, decreased peripheral perfusion. We're going to see oliguria. Remember, a decrease in their urinary output. For infants, oliguria is less than 1 milliliter per kilogram per hour. For children, it is less than 0.5 milliliters per kilogram per hour. And I'm going to ask you when we are in class, why do you think the numbers are different here? All right, and we're going to talk about that. All right. As far as management of dehydration, it is very much like an adult initially. We're going to want to immediately expand the extracellular fluids very quickly. We are going to do a isotonic bolus solution. You will probably see normal saline. That is what we generally use for adults and children, but you can see there we're going to replace the fluid 20 to 30 milliliters per kilogram. So we're not just putting 1,000 milliliters in really quick like we may an adult. We're going to have to be more prudent because we can certainly overload them very quickly. All right. Second part of managing the dehydration will be replacing the deficits, the losses, and the maintenance fluid. So that's where those maintenance fluid calculations, come in. Finally, when the child is in a better state health-wise, they can start to take in oral rehydration and feedings, okay? You can see there what a sodium deficit is in a child, what hyponatremia is. This is something you may see, not that uncommon. The causes are often gastroenteritis and fluid overload. All right. There's that worksheet that we are going to do together in class. So tissue integrity does play a large part in fluid balance for adults and children. We're going to talk about the extent of burns. We have first, second, third, and fourth degree burns. We're going to look at a picture of that soon. Anytime you have a patient, anytime, that has a burn, your first concern is going to be about an inhalation injury. As far as extent of burns, adults follow rules of 9, all right? The younger the child, we don't necessarily follow, we follow rules of 9, but we calculate it very differently. And we're going to go through several exercises calculating burn percentages for infants and children, okay? The different types of burns can be thermal, electrical, and chemical. Thermal is flames or hot surfaces, hot liquids. Electrical could be household currents or lightning. And chemical, that could be very acidic or alkalinic compounds, okay? All right, so here is a picture of how we're going to calculate burns. It's going to be based on the percentage of body surface area. But you can see at the bottom here, it is different, all right? The reason why it's different are infants, children, as they grow, are proportionally different than adults, all right? So if I tell you that it's just the entire front of them, it's only going to be 13%, right? But if I tell you it's going to be the front, their chest and abdomen, and both upper arms, you can see there we'd be 13, 14, 15, 16, 17, right? Moving on, when we're talking about legs and head, it depends on the age, all right? And we are going to go through this in class. This is a very important picture to become familiar with. You do not have to memorize it, but you do have to be able to understand it, all right? The extent of the burn is categorized first, second, third, and fourth. You can see here the first degree burn is just the epidermis. The second degree burn is epidermis and dermis. Third degree is fully through skin and fat. And fourth degree will extend all the way to the muscle. All right. And this is right here is a good picture because you can see here, this is first. Second, we're getting blistering. Third, you can see here, third right here. And then fourth all the way down to muscle, excuse me. As far as providing care, the most important thing is establishing and maintaining an airway. We're going to want to replace their fluids, provide wound care, and assess for complications, okay? We're going to talk about some of those complications in just a minute, all right? As far as fluid resuscitation, hypovolemic shock is a major concern within the first 48 hours, all right? So when the skin is disrupted, massive amounts of fluid leak out. So you're going to see a shift from the extracellular fluid spaces, so interstitial and intervascular, and it's going to cause a shift into third spacing and edema, all right? This, when you get to third spacing and edema like this is no longer viable fluid, so they can go into shock, all right? It also shifts into the intracellular spaces, all right? So you have to be very careful. You would assess things like capillary refill, alterations in sensorium or level of consciousness, okay, and urinary output. As far as taking care of your patient. We are going to do fluid replacement. I will tell you that fluid replacement in a burn patient is not calculating maintenance fluids until they're completely stable hemodynamically. So what you're first going to do is calculate different ways. And the most popular fluid replacement for burns is using the Parkland formula. We are not going to go into that. That gets very much in depth. You don't need to know that, but just be aware that fluid resuscitation for burns replacement is going to be using a different formula, and the one that we use most often is called a Parkland formula. TPN would be given if we are worried about an inhalation burn. Okay. It will also be given when and if the patient is MPO for the first 24 to 48 hours. All right. Remember that children cannot go long without eating or having nutrition. All right. So to be MPO, we'd assess the airway for inhalation injury. If we see any injury to the nose, mouth, trachea, lungs, we're definitely going to make them MPO. They may need a G-tube depending on the extent of the burn. And you can see a picture there of a child with an NG tube. Understand that if there's any suspicion of an inhalation burn, they're going to be maintained MPO for the first 24 to 48 hours. If their burn is more mild, they will not be MPO, because the more ways we can try to rehydrate them, the better. So we would encourage them to drink fluids and to take in nutrition. Okay. GI dilation is specific to help prevent strictures and prevent scarring. Okay. Strictures and scarring will prevent function. We certainly don't want that. Also, it can be very painful. Children with burns usually require an increase in carbohydrates and fat intake. They'll usually require a multivitamin and iron, because anemia is a systemic response to burns. So you're going to see children with iron supplements, okay, after a burn. And as far as ways that we're going to help treat this and what we can expect, well, we have to excise dead and necrotic tissue. All right. It does reduce the risk of infection. I will tell you, this is an instance where you will be doing dressing changes sterilely to prevent infection, because infection is one of the biggest complications after a burn. You can see the different types of antimicrobial agent that you would put on first, and then the dressing. These are those types of ointments and creams that you don't have to completely clean out after. With each dressing change, you clean out the bulk of the wound, and then, but if there's some left over in there, you can certainly reapply. Temporary coverings, you can see here, biosynthetic coverings, synthetic like Tegaderm. Skin grafts can be done to help with skin replacement, to help prevent contractures. Skin grafts can be from a donor or can be from the person themselves. They can be partial thickness, full thickness, and so there's lots of different ways that repairs can be made. So the next complication of a burn would be in about 48 to 96 hours after the injury, the fluid that's in the intracellular spaces and in the tissue that's still viable will shift back into the vessels and the blood volume will increase. This will cause an increase in renal blood flow, which will result in diaphoresis unless there is renal damage. So this is something you have to watch very carefully for. Fluid overload can occur related to that intravascular fluid volume, that increase, if the kidneys aren't functioning properly. And remember, we talk about lack of perfusion to the kidneys. This can cause an acute kidney injury where the kidneys function is decreased. So we talked about the hypovolemia. It could have affected the kidneys. So we have to be very careful with this fluid shift. Now, while we are assessing, you can see here the assessment we have to do to watch for this. We have to listen for lung sounds and listen for crackles, right? Also, we need to assess their edema and that status. Okay, so those are constant evaluations that we have to be making after a burn. Other complications related to burns, you can see their sepsis. Pneumonia from them not moving around much. You can see their GI bleeding. Those are based on extent of the injuries. Contractures, especially fingers, toes, if there's burns there. Hypertrophied scar formation, so thick scars that burn and itch. Disfigurement and psychological issues, because there's going to be changes in physical appearance, okay? This is a picture of hydrotherapy, so you can see them. They have their masks, they have hairnets, they're in their gowns, they are sterile initially when they start, they have sterile scrub brushes. You would give your patient medication prior to this because it can be very painful. You're going to let them soak in that tub to help the water debride first. When you give someone pain medications and put them in a tub, you better watch them. You better watch them so that they don't become sedated and unfortunately drown. So you have to be very careful and mindful of that situation. After you leave them in the water for a certain amount of time, you can use, unfortunately, the scrub brush and debride the rest of the wound. I will tell you that in the last several years, artificial skin dressings are used to help with healing. What we use often is called Integra, and this is an artificial skin. We are going to stop there for this podcast. When we return, we are going to discuss different types of dressings.